stage, some of you, and welcome a new person to the stage. So, yes, we're going to have a panel discussion right now. I want to make just a few suggestions as well as we start this panel discussion. For those of you in the audience who might have some questions, we have or we'll be sending out some post-it notes on the tables. So if you have questions, fill them out, raise your hand. We have volunteers ready to take them from you, and they will somehow magically be converted into electronic form and end up on my phone. Somehow, I don't know. For those of you watching on the live stream, send us your questions via Twitter with the hashtag MedX. They also will somehow end up on my phone. I actually have helper, Ravali Reddy, on our Medicine X staff who will be curating questions for me, for us actually. I am very honored to be joined by Heather Davidson, my co-moderator on this panel, because it takes two of us to co-moderate, everyone included, panel. What we wanted to do for the purpose of this panel was to explore a question. And the question is, why is this so hard? Why is it so hard? Yeah. Why is everyone included? Why is collaboration? Why is interprofessional learning and work so hard? And so that is what we want to try to do over the next 20 minutes, is to explore this question together with the amazingly diverse speakers that have been on the stage, and with the new guests that have joined us. And Heather, maybe you would like to introduce our guests and throw the first question.
Well, so I'd like to hear from Andrea first, because I'd like to know your story, and I'd like to know, why is this so hard?
Yeah, I mean, why? So a little bit about my background. My name is Andrea Downing. I am an e-patient scholar who has come through this program, and really thankful to Medicine X because it's really helped me to find my voice. You know, I am kind of looking at this through the lens of how might we change the dynamic from patient as passive subject, as somebody who you study in a textbook and a case study or a cadaver on the table, or in those mechanisms, to an expert as a partner, as somebody who can really tell their story in an empowering way. And I'm coming through this as a person who has been a guest lecturer at Weill Cornell. I have, for the past 3 years, shared my experiences with med students there as a previver, carrying a BRCA1 mutation, what my journey was like, but also how my journey fit into a bigger picture of personalized medicine and some of the activism and advocacy that I do. So, you know, to ask why it's so hard, I really, if we change our thinking, if we change the culture, if we build trust, I really don't think it can be so hard. I think it's actually going to be very powerful and amazing if we do this. So thank you for having me as part of this panel. Yes, that's my story.
How would you all answer that same question?
Well, I guess I'll jump in on one thing, because a lot of times I think we actually believe we do this well. And when I started where I was, we have clinics that had embedded pharmacists that reasonably the past several years, embedded psychologists, embedded social workers. That sounds interprofessional. And yet what I found that we were doing was that whole co-located care, where basically you had a lot of people of different professions in one room, but you never talked to each other. Even with electronic records, it's frustrating to communicate. Of course, it's also easy to communicate. You kind of put the phone down, the world's biggest virus, and go and talk to somebody. And I think that's just what we've forgotten, is the need for that communication. And so we keep talking about warm handoffs and that collaboration where there's communication with the patient truly at the center, so that you're directing what's going on instead of you being a virtual patient or somebody we just talk about around a desk. intellectually. And that's, it should be easy, I agree with you, but it's still, I think we struggle.
I think we have to agree that I'm about to say blasphemy, so I will begin by starting that. Us in medical education are typically not taught to teach. We're taught to be scientists and clinicians. And so there's an ego that we all have to agree we need to go talk to our education. So I found the first plenary extremely important. I think one of the issues at the center of this is just admitting that we need some help from our educational colleagues to say how do we create these things to better measure educational outcomes. I think that we all sort of think we're doing something good until we talk to the people who have the evidence on the education side, and we find that we've been perpetuating myths for a very long time.
I think certainly to add to that is we have to go even more basic. The dynamics of the healthcare team has just not changed in a lot of geographies. It's still very much doctor-patient. And I think back to a line I put out on social media last week, which was that behind every doctor, there's a better nurse. And it's true. And if you actually look at the dynamic of the team, it has to change. We have to get rid of barriers, visual barriers. I mean, simple things like white coats. Why are they there? They naturally, subconsciously distinguish the doctor from everyone else. It's unnecessary. It's so the team has to involve the doctor, the nurse, the allied health professionals, the midwives, community health workers, and ultimately the patient at the center of it. But we're just not seeing that everywhere.
So let me take a moment to ask a question to the panel from the audience. From Twitter, actually. Nicole Capadarest, I'm sorry, Nicole. How do we change the dynamic from patient as subject to patient as expert, or someone who has expertise? So I'll throw that out to the panel. Is that something that, if we implemented, could help make things easier in terms of promoting a way of collaboration in medical education? And how do we do it?
I think one thing that we don't talk enough about is the human developmental path, right, in terms of your own health and the way you think about it. And so, for instance, it's never static. The person's story when they first come, when they're first diagnosed with a chronic disease, is a very different story than how it is later into maintenance or later into moving past it. And that change in which they tell those stories is this very human. We all know this about anything we do, right? It's very human. And so to start to look at the way that our, the people that we work with tell their story as an indicator for where they're developing in their own identity, in their own way of thinking through their journey, is a very different approach. Because it's not, when I think of subject matter, sometimes like dissecting a frog in junior high comes to mind, right? Because you're looking at the small pieces of the inside of a frog and trying to understand what the body parts look like. And that is just totally different from the dynamic nature of what happens in a human being as they're trying to reconcile something that has, either in primary care, meaning they're just wanting to stay healthy and well, or they have a massive change in their life that has changed their identity. And so I think one of the ways in which we start thinking differently about passive to active, subject, to participant, partner, is that we start recognizing this very multidimensional, very dynamic, moving, changing growth in human beings.
So could I just add from the allied health fields, and especially from occupational therapy, I think actually part of what we teach our students is storytelling and motivational interviewing and how to understand the person's narrative. We study a lot about narrative medicine because we think that these things are really important for our students to be able to take into the clinic because of this, exactly what you said, which is that everybody has a story and our job is to just help them write the next chapter of that story.
Yes, the key question for me was how often, especially early on for you, were you put at the center where people truly did ask you what matters most, or for you to actually have control of the interview for as long as you needed?
It took me 6 years of struggling through the healthcare system, through not getting the support or the information that I needed to make informed decisions. And I'm gonna, can I tell you a quick story about like the, can I tell you a quick story? Okay, so I just to answer that question very quickly, I think one of the things that we have done with a lot of the e-patients in this room is we have equipped them with the tools to become experts. So there is a difference between just talking to a patient who's going through this experience for the first time and talking to somebody who's kind of gone through the experience and been there for several years, but then has switched into kind of this advocacy role and learned about the bigger picture. So within my own story, I actually met the professor that I co-lecture with at the steps of the Supreme Court. So here's the little backstory. I started a blog called Brave Bosom, and that was really the beginning of my path as an advocate. I started writing about a case that was then in federal court about whether human genes could be patented. And the case happened to have the company that had done my genetic testing. And luckily, at the steps of the Supreme Court, we were all celebrating because human genes patents were overturned, and that opened up cancer research. But then going to these lectures, so he invited me, and he wasn't sure what was going to happen. I think he was a little bit nervous too, but he was open to trying something new, where we were actually co-lecturing together. And it was magical. I will say to you that last year I got up and spoke, and we talk about everything. We talk about, my identity as a previvor, how that fits into a bigger picture of personalized medicine. But the really powerful thing for me in that experience is the med students who come to me afterwards and say, this is one of the best things that I have experienced in med school so far. Now, they are first years, so I don't want to, and it was like early in the semester, so not setting really high expectations there, but I've kept up with some of them. I've had they've exchanged emails with me, and I follow their path. And it's really important to me to see that, starting in the first year of med school and being able to change that dynamic, because it does lead to the future of education and medicine, is incredible.
I mean, I think the power of stories is also in their ability to influence even just the formation of identity as our students become doctors, and influence the kind of doctor they're going to be. So Medicine X, and for those of you who can make it, on Sunday at around noon, I think 12:30, our student partnership track is going to talk about the 2-month project that we have looking at connection and identity. Where we partnered patients with healthcare students for 2 months and are exploring the role of connection between connecting patients with healthcare students in a prolonged 2-month relationship of getting to know each other, and how that might impact the formation of identity of who they become on both sides by learning more about what it's like on the other side. And the impact of not only stories, but of connection and the formation of their individual identities in improving the ability to collaborate.
Yes.
And so I think even just being in the same room, I love that slide, work together, learn together. We have to be together, right? That makes, it's simple, but it's maybe a simple truth.
What's really sad to me is that your experiences when we have at ETSU, where we bring real patients in with first, second, third, and fourth year medical students, basic science review, et cetera, and it's powerful, and you pat yourself on the back from an educational perspective. But for that to be so unusual that people say to you, that's the most powerful moment of school, tells you everything wrong with our system. Because it's like, it shouldn't be, yeah, it shouldn't be that weird. It should be the basic, and yet we have turned everything on its ear that you're not in the rooms, you're not there for the stories. We rarely get you there in the formative years. And by that time, then we have all these restrictions and time limits and chart care rather than patient care, and I don't have time for your story. So we've got to shift it. So why is it so hard? Because the mastery that our learners get is mastery of a dysfunctional system. They understand how to make a bad system work enough to get through. And that's where I think so much of it needs to be there. So thank you for your bravery to do that, but we've got to get to the point where everybody says, oh yeah, another patient, that's good, that's what we're here for, as opposed to, wow.
Right. But I think we need to bring it to the postgraduate level as well. It's not just in the initial years. And it's because you look at classic examples where you need multidisciplinary teams, you need patient involvement. A good specialty, for example, would be endocrinology and diabetes management, for example. And you don't want your healthcare workers, after they've done all their training, to just be seeing these individuals in their postgraduate learning as the diabetic. It has to be patient A, patient B, with names, with characters. And so curriculum design and instructional design has to ask individuals like yourself, where can you put the input in? Where can you start doing a virtual collaborative session or tutorial together with us? Because that's the only way you're going to end up reminding these physicians and healthcare workers down the line that you're still the center, and but also, more importantly, part of that learning team.
I think there's a really powerful lesson to be learned with that, which is, when you combine the stories with the data and see the living person, then you see that there's something behind the facts and the research, and that changes the culture in the very beginning. I can tell you, just having experienced research as a participant, that is the first thing that needs to change. We have to build trust. We have to understand that there is scientific rigor that we must follow, and I think there's a way to do that well, where there's the story of the person or the reasons why we're doing this research in the first place, and we move beyond just tokenism. That's another really important thing. And I know a lot of e-patients in the room have heard this word before, but not just having a patient tell their story and just like patting us on the head and saying that's great, but actually co-designing with us, building the curriculum based on, for my particular scenario, how do you talk to a previvor? How do you understand, the shared decision making, and the personalized messages that are emerging in breast cancer screening as the research changes quickly. These are the things that e-patients in the room are incredible resources for, and we've equipped them with the tools to do that. So I would love to see them as part of these programs in a more formalized way as partners, not just token patients.
I think we need to stop doing things to patients and do things with patients.
Gets a round of applause from the audience. Okay. So we have another question from the audience. Current health professional training programs teach and assess individual competence. How can we teach and assess collective competence?
I think we do aspects of that at the governmental and policy level when you look at key performance indicators in health systems. But the issue is that they're just numbers to convince politicians as to what to do next. What you need to do is use technology to actually see, and this is the big dilemma we have in education, is that does any educational intervention actually improve health outcomes collectively? Mm-hmm. But we're now seeing, and certainly from some of the research we've done, is that actually if you integrate at key points along the educational line, patient input, monitoring the data of, let's say, sugar levels in diabetes patients, you can then start seeing over a 2-3 year period these KPIs changing because of the education. But I think that is going to take time, and we're only going to see that now. Right now, I think we're not being able to do it properly.
I think the other question is what it is that we're supposed to measure, and maybe I'm the only one in the room, but I'm not sure we're clear on what that is. So I guess maybe there's one other person. I think that's part of the problem. So part of the reason we stay in our silos is it's way easier to measure our individual pieces of knowledge, as flawed as our measurement is, than when we put a group of learners from a whole bunch of different backgrounds and say, okay, do something,
Yeah.
and then measure it sort of in this kind of touchy-feely process. There needs to be as much rigor on that side of things. So I'm not sure we're clear on what it is we're supposed to measure, and therefore the bridge from that to outcomes of clinical dynamics is the bugaboo that we're dealing with, I think.
Well, and I would jump in to also add that, you know, all of us say it a lot, which is the communication dynamic stuff is the soft stuff, right? It's like, and I loved a comment that one of our medical students said the other day, which he said, you know, learning the science is basically pretty easy. I mean, like, it's hard, you have to work hard at it, but you know, it's there and you have to learn it. He said this, learning how to work in teams and groups and have the dynamics of individuals and bring out the best in people, he's like, that's really hard. And so I think that challenging, you know, one of the challenges for us is to look at those disciplines and those people who have been thinking hard about what community is and what activism is and what, you know, what it takes for groups to bring out the best in business or in science or in other things, and look to them to what types of outcomes are really resonating with them and start bringing them more into education, and to start using language that the communication piece is hard. It is a vital skill, and it's something that we have to be making sure that we actually start using language in a little different way too, to elevate that.
Well, please help me thank this panel and this group of experts for helping us with these challenges, because this is difficult work, it's important work, and the book is not written yet, but we are writing it together, and we're going to get there. So thank you very much for this wonderful session and for these wonderful speakers.